is Katie Ludwig. I'm an FY2 junior doctor at Tameside General Hospital, which is a small district general in Greater Manchester. I'm going to be talking about a retrospective study that was completed this year, looking at the wide local excision reoperation rates at our hospital. The study was completed in order to compare our reoperation rates with those throughout the country, particularly in NHS England. So I'm sure I'm preaching to the choir here, and I'm sure you all know these statistics, but so according to the Cancer Research UK, about 50,000 new cases of breast cancer were diagnosed in 2011. Well over 11,000 deaths were caused secondary to breast cancer, and currently, for women, Cancer Research UK quotes a 78% 10-year survival rate, with 27 of those are felt to be preventable. So after diagnosis, according to an article published in the BMJ in 2012, 58% of women diagnosed with breast cancer opt for a breast-conserving surgery. So breast-conserving surgery is where the tumor is taken out with a normal surrounding margin of tissue. It's felt to have a better cosmesis and has similar survival rates with those in mastectomy. However, it's important to realize that 20%, 1 in 5 women with breast cancer who have opted for breast-conserving surgery rather than mastectomy go on to have reoperation, and that's really what this study was looking at. So for wide local excision, I wanted to initially look at what the NICE guidelines say, so the guidelines that surgeons in Britain compare themselves against. Once the tumor has been excised, they want a 2 millimeter margin of normal tissue around the area. This tissue then needs to be microscopically reviewed, and if it's less than 2 millimeters, it needs to re-excision. It needs to be considered and is strongly advised. So before we started collecting data, we looked at other studies in the country that had looked at similar issues, and we found a large cohort study looking at 156 English NHS trusts, and we used this as our benchmark study to compare. So this study included 55,297 women, and these women had breast-conserving surgery only. However, it was shown that 20% of these women went on to have at least one reoperation. They also noticed a variance in the number of reoperations due to histology. So about 30% reoperation was noticed in women with a carcinoma in situ, whereas only 80% had a reoperation if they had an isolated invasive cancer. Of the 20% that had the reoperation, instead of having further breast-conserving surgery, they went on to have a mastectomy. So from our point of view, our collection method, it was anonymous data was collected from Medway, which is our electric database. Information was collected from clinic letters, histology, and radiology letters as well. The study dated between the 1st of April 2012 and the 21st of August 2013. The study considered only patients that had had a wide local excision and then went on to have further excision. If you had, after your initial operation, if you had any further operation to your axilla, you were excluded from the study. And it only included patients who had reoperation to the ipsilateral side that was ipsilateral to the side of the initial operation. And the reason for reoperation had to be due to histological findings rather than to an early recurrence of the disease. So it ended up being a relatively small study. 77 patients in that predefined time period were found to have a wide local excision. 14 of those had further surgery, either of a mastectomy or breast-conserving surgery. So breaking that down further, 8 had a further excision and 6 had a mastectomy. And then if we're looking further into those 14 patients, 11 patients had a bigger tumor on histology post-operatively than indicated on the radiology report pre-operatively, which is something that needs to be fed back. One tumor was noted to be smaller on histology. However, that patient actually ended up going for a full mastectomy on reoperation due to advanced disease within the lymph nodes. Just as a note, eight of the 14 that had a reoperation had cavity shades during the first operation. So during their first wide local excision, they had cavity shades judged by the surgeon when they removed the initial tissue. And I think it's quite interesting that in comparison, if we look at the patients who didn't go on to have reoperation, so that's the 63 left, 17 of them who again didn't have any further reoperation had cavity shaves. So if you're comparing those percentages, I think the surgeon already has quite a good indicator whether someone's going to need a reoperation when they're not, because obviously more of the ones who are having cavity shaves and the surgeon might not be happy with the initial tissue removal had to go on to have reoperations. So when we're looking at the mastectomy versus the wide local excision, again, I've already gone through these numbers. 8 went through further excision and 6 had a mastectomy. But the reasons why they had the mastectomies were 2 or more of them had, 2 cases, there were 2 or more close margins on histology, and in a further 2 cases, there was extensive lymph node involvement noted. In all 4 of these cases, it was felt that mastectomy would be the better option of choice in order to take out all breast tissue. In one of the cases, they had initially tried for a wide local excision on quite a large tumor, and they had excised it, but all the margins were quite close, and again, it was felt that it was better to go for removal of all breast tissue rather than risk of further excision. There was one case where a squamous cell carcinoma was extended posteriorly, and again, it was felt that a full mastectomy was the best option. Just because the benchmark study that I had previously spoken about indicated that there was some differentiation between the histology reports and how many of those patients needed to go on to have reoperations, I thought I've included our histology reports for those that had to have re-excisions. So 8 of them had IDC, 4 had IDC, but also was noted to have DCIS, either on the margins or in a foci away from the main site. There's one case of mucinous carcinoma, again with a DCIS on a foci away from the main lesion, and as I previously mentioned, there's one case of a squamous cell carcinoma. So just as a quick summary, our reoperation rate is about 80%. Further, in terms of those who've had the reoperations and further operations, 43% of those went on to have a mastectomy, with 57% of those going on for a breast-conserving surgery. Within the whole study, we can then say, looking at the 77 patients, that our further excision rate is 10% if you were going to go on and have a wide local excision, and our mastectomy rate is 8%. So just to conclude, nearly all of our tumor sizes were underestimated on radiology, which I think is important, one, to feed back to our radiology department, and also just for the surgeons at our trust to be aware of that, and then that will implement their technique during surgery. We do have comparable reoperation rates with the cohort study, which appears favorable for us. We have potentially marginally higher mastectomy rates. So our reoperation rates were 18 and the cohort 18%, whereas the cohort study quoted 20. Our mastectomy rates are 43%, whereas the cohort study quoted 40, but really the numbers that we're talking in our study were so small that it's quite hard to compare. I really think that a larger study with more numbers would need to be done before any firm conclusions or any change in practice could be implemented. But really the point, and I think the reason why we'd want to go forward and do a bigger study, is so that as a trust, especially with all the new CQC and changes that trusts are being encouraged to implement, we want to be able to give an exact number to our patients of the risks of reoperation when we're offering surgeries like wide local excisions, and how we're comparing with other trusts throughout England. And so if we're doing studies that show that we're comparing favorably, then that can only be a good thing. But thank you very much for listening. I'd like to acknowledge my peers and my senior colleagues who helped me with this study. And I'll take any questions.
I do have one question. So do you have a breakdown of how close the margin was in these cases?
That is something that we'd want to look at, and we haven't broken that down yet. We'd have to then go and ask, in further surgery, we'd have to ask the histologist to give further details and go through the histology report. I think at the moment what they're reporting is that it's less than 2 millimeters, and they're not reporting necessarily that, well, how close it is. But it's definitely a really good point, and we want to see how close we actually are. Yeah.
Thank you.
Thank you.